Thanks, Aleece. Over to you.
Thanks very much, Monica. Um, and thanks really for the invitation to be involved today. I really appreciate the opportunity to be here. I'm going to speak about outcomes of invasive fungal infections in ICU in haematology and oncology patients, with a real focus on invasive mold infections primarily. Um, so I don't have any conflicts of interest to declare, but I would like to acknowledge these organisations below that have contributed to some of the data I'm going to present, and also particularly to Zoe McQuilton, Claire Dendall, Dave Pilcher, and Monica, who are four of my five PhD supervisors. And this isn't exactly work from my PhD, but it does draw from some of the work we've done together. So I think it, kind of goes without saying why invasive fungal and invasive mold infections in ICU is an important topic in haematology-oncology. These are very high morbidity and mortality infections, and often, the point of admission to ICU is a decision point for the direction of care for these patients. And for patients who are admitted in ICU, it's also often there are a number of decisions to make around empiric treatment, sometimes in the absence of adequate diagnostics, and secondary prophylaxis and prognostication are all challenges that we face. And for context, there's a lot of data to indicate that outcomes on the whole for critically ill patients with heme malignancies are improving. The figure on the left is a study from my PhD looking at sepsis mortality in Australia and New Zealand that included about 17,000 patients admitted to ICU over the last 20 years and showed improvements in sepsis mortality independent of a number of baseline clinical factors, including age and comorbidities. And there are plenty of trajectories, plenty of figures like that you can see in other areas, but how that applies to invasive fungal infections is less clear. And the figure on the right is from a discussion piece by Abby Douglas and Monica, recently published in TID, focusing on stem cell transplant recipients, but the same principles apply elsewhere, looking at how, I guess, the flip side of survivorship and new low intensity regimens is a changing patient cohort of older patients with more comorbidities. And similarly, the flip side of antifungal prophylaxis is that an increasing proportion of infections are breakthrough atypical organisms. And so, what data do we have available to try to get a sense of how these patients do when they're admitted to ICU? It's actually a really difficult question to answer with the available epidemiological data for a number of reasons. One is that in the grand scheme of things, we're asking quite a specific question that is actually relatively rare, and that is, we want invasive fungal infections in haematology-oncology patients in ICU. And the available data often looks at some overlapping subset of that. So, maybe we're looking at a critical care cohort of hem-onc patients and pulling out the subset of invasive fungal infections, or maybe we have some IFI data and we pull out the subset admitted to ICU. And another downstream effect of that sort of data is that the case ascertainment really varies depending on the definitions that are used, and those definitions link back to what the primary purposes of the data was, which may not be the exact question we're trying to ask. So we're all familiar with the EORTC definitions, but those aren't the only clinical case definitions that are used, and others, particularly when an overall or immunocompetent population is included, can be different. And then clinical registries will often use clinician-coded diagnoses. Some will use culture-based diagnoses, and administrative data sets will use ICD-10 codes. And it's not really about those definitions, one being better than the other. They all have strengths and weaknesses. The important point is that they're not interchangeable. And so it can make these data very difficult to compare. And as a general rule of thumb, if you've got a low sensitivity and high specificity definition, you are selecting out for patients that can meet that definition who may have a higher burden of infection and therefore higher mortality. So with those caveats in mind, there is some useful international data that we can draw, and I'll start with the general and then try to get more specific and describe some local data at the end. So in the crit care and hem-onc space, there are a number of big multi-centre and national level cohort studies. Not all of them report IFIs, but a handful do, including a big study from Canada and some multi-centre studies from France. And then, we can also look at big cohort studies or registry data of all comers with invasive fungal infections. So, for example, in France, there's big multi-centre prospective surveillance of IFIs for probable and proven infections. And closer to home, Shoyentio's recent multi-centre cohort study of invasive aspergillus in Australia gives us some more recent and local data as well. And I guess starting with the overall heme patients, the first comment to make is that if studies don't report specifically on IFI, they can be pretty hard to find because the most common admission diagnoses or admission issues are respiratory failure, sepsis, and pneumonia. So IFIs can be hiding anywhere in there. But having said that, among the subset of studies that report probable or proven IFI, it looks like about 10% of all patients with a haematological malignancy admitted to ICU have a probable or proven IFI. And flipping it over to look at all comers with IFI, looks like about 20 to 25% of patients with heme malignancy and IFI get admitted to ICU. And then across both of those kind of bigger, more general cohorts, most IFI are still invasive aspergillus at this stage, acknowledging sort of shifts in the background happening as well. And the mortality rates across both cohorts sort of sit in the 30 to 50% range, with a number of caveats about heterogeneity of populations. But the risk factors for mortality are fairly consistently reported to do with relapse and refractory underlying disease, frailty, and organ failure. There are a couple of studies that look more specifically at the question we're trying to answer here, which is what are the outcomes for patients with hematological malignancy and invasive fungal infection who are admitted to ICU? So Ali Azouli and colleagues in France have done a lot of work in critical care, and one of their cohort studies reports on about 78 patients with IFI. And then there's also a study from Germany with another 89 patients looking at IFI and ICU. And these two studies have found fairly similar findings. I think the take-home messages are, in terms of who these patients are, so again, about 3/4 have invasive aspergillus. Not all are neutropenic and not all are acute leukemia or stem cell transplant patients. So about 40% neutropenic, about 40% acute leukes. And the mortality was high. In the French study, 54%, in the German study, 63%, and that mortality was higher than other critically ill patients without IFI. And the long-term outcomes for patients with MDS were really, really poor. All of the patients identified in that study died within 12 months, but not quite so bad for patients with myeloma. And then the figure on the right there just shows there was a lot of so in summary, heme malignancies and invasive fungal infections are, a really dangerous combination when patients are critically ill. Of those with heme malignancy and invasive fungal infection, about 1/4 are admitted to ICU. Of those with heme malignancies admitted to ICU, about 10% have a fungal infection. And that group is diverse. They're not all AML. There's also patients with lymphoma, and not all patients are neutropenic. The mortality is about 50%, and that's been pretty consistent, including in recent years. But the epidemiological data we have has some real interpretive challenges. And some of the caveats and questions here relate to the heterogeneity of the population, the length of the time period, the recency of the data. And I think a really important consideration is, are we achieving similar outcomes in a different patient group, and really selecting out for the patients at highest risk. So I'll wind up there, and thanks again for having me, and I'll pass back over to Monica.
Thank you, Aleece, and thanks for really digging through the data to find what there is, local data. It's very, it shows, I think, your expertise with these